leg gently in an attempt to regain a pulse. Good. Oh wait, you guys chose place the left leg in its anatomical correct position and splint. The correct answer was attempt one time to move the leg gently in an attempt to regain a pulse. These are both correct. That's one of those questions. They're both correct, but ultimately we have to try to get that pulse back if possible. So I can see that why that's the correct answer. Okay, next one. Which of the following is the best indicator of an imminent delivery? So the baby's coming. Grounding, perfect. That means that the baby's head is starting to show and come out. Which of the following terms is used to describe body parts found the same on either side of the midline? Bilateral, that's the correct answer. Bilateral means both sides of the body. So if your patient broke both of their femurs, they have bilateral femur fractures. If it's only on one side, it's called unilateral. Which of the following is true regarding the utilization of a shortboard device? Place the patient in a better position. See, which of the following is true regarding utilization of a shortboard device? Give me a sec, guys. I'm gonna double check this one. I'm sure that it's right, but a shoulder roll. Let me see. This is the explanation. Rolling the shoulders back will place the patient in a more natural position. You should not pad behind the neck, as this can produce a pivot point. Well, you only pad if you have to. That's the point there. So that's why that's the answer. Most of you chose the shortboard can adequately immobilize the entire spine. That is also true. Which of the following types of helmets is most likely going to require the alternative method of helmet? Face. Last one. What is a primary concern when a person becomes unconscious following an injury to the head? Okay, good. He may be unable to control his airway. So it comes down to airway management when it comes to head injuries, okay? Airway management when it comes to head injuries. Some of you guys put internal bleeding may cause shock. Internal bleeding can cause shock, but we're talking about a head injury here, okay? So internal bleeding can only cause shock from the bleeding itself, if it has a cavity big enough to fill that blood. So that's why that's not the answer for this question. Okay. Okay, so I'm gonna go ahead and start off with a video before I go into the lecture. Let me share that real quick with you guys. I think it's on there. Share, preparing to care. Here we go.
Teach nurses, nurses empower nurses, train the trainer is how we do it. Who knows best but the nurse at the bedside, how to take care of the patient. When you're dealing with an older person, you have to make sure that you take time to get to know them. You help them to feel comfortable with you. So you're patient from the beginning. You don't go in, we need to do this examination, so you need to take your clothes off and put on this gown. You have to establish a relationship with them first. We have an All About Me board where we ask them questions. What do you like to be called? When do you prefer to have your bath? What temperatures do you prefer? Because not everybody who's old is cold all the time. We make assumptions. Not everybody who's older have hearing deficits. They can't take the medications that you and I can take all the time. So you start low on the medicines and increase as needed. The older adult has special needs, just like, if you're dealing with pediatrics, they have special needs.
My dad was just the best guy in the world. And, I always knew it. My father's sense of humor is one of the first things I think about when I think of my dad. He was always a GQ kind of guy. He was a CPA, very well-groomed, very much cared about that sort of thing. He worked out at least 6 days a week, often 7 days a week. Didn't want to skip a day because he was afraid there would come a day he would have to skip that week.
These people have lived full lives. They have a certain degree of respect that you have to give them. But even if they have dementia and they don't know their name, they still deserve the respect. They still deserve, the kindness, the conversation, even if they can't converse back with you.
He had a terrible stroke in March 28th, 2011. It occurred to me with my dad in the hospital, and as long as he was in the hospital, that geriatric patients do need to be treated differently than other patients. UAB has a program called Geriatric Scholars, and nurses who want to learn more about treating geriatric patients participate in an intense training program. And I know this because we had a wonderful nurse, and she was the first nurse who took care of my dad and was a geriatric scholar.
We have 52 scholars. We select scholars from applicants who have expressed interest in caring for the geriatric patients, and they are chosen to become the scholars for the hospital. And their role is to make sure that they become, first of all, educated in taking care of the geriatric patients, and later to become consultants for whoever needs help, first on their units and throughout the hospital.
During moments of delirium, she could see that he was agitated and his hands were moving, and he was looking at the ceiling and talking. She would give him something to do with his hands to keep him, I think, to keep him grounded and maybe pull him back into himself. And she just was wonderful. The care she gave him was above and beyond. get to the Geriatric Scholar Program.
So now the baby boomers are turning, within the next 5 years, they'll be 65 and older. And we have to be prepared to take care of them. The bottom line is people are living longer, and people are living longer well. We have to be prepared to take care of the unique needs that they have. These people have done great things, and they deserve our respect. It's amazing.
Okay, so now I'll get into the lecture. Is Desiree here?
Yeah, I'm here.
Hey, I couldn't find the documents. You said, did you email them to me or give them to me in person?
No, I emailed them to you a long time ago, but if you want me to email them to you, I can again.
Yeah, please. I was looking, I couldn't find it anywhere. So if you can, it'd be awesome.
I figured. Okay, I'll email it to you today.
Okay, thank you.
Okay, thank you.
All right, so geriatric emergencies. It's a relatively short chapter. So, like it says here, after age 30, most organ functions start to decline by 1%. Now, obviously, this is attributed to it has to do with genetics mainly. So some people decline faster, some people decline slower, but this is just in general it's talking about. Of course, along with that, maximum heart rate declines because, like I said, after age 30, your body starts to just decline in general by 1% altogether, all functions. See, older patients with internal bleeding will not exhibit heart rate as rapid as expected. So this is because, again, it's going back to the fact that everything is starting to decline. So they can't compensate as effectively as they used to when they were younger. So that's why you won't see that increase in heart rate during bleeding to compensate for that loss of blood. If unaware, EMT may miss what older patient is in shock, or when older patient is in shock. That old, sorry. Mental status. So yeah, so because of that, because of the fact that we can't really depend on the patient compensating and showing us signs of compensation, we want to depend more on the patient's mental status more than anything else to let us know how they're doing. And that's from when we get the patient until we deliver them at the ER. So you're really gonna have a big focus on mental status when it comes to your geriatric population, which I believe is 65 years or older. See, causes of patient communication difficulty. So these are reasons why you would have issues communicating with that geriatric patient. Again, because everything is starting to decline. Hearing loss, that's a big one. But again, just because the patient is geriatric doesn't mean you have to scream right off the bat. First, try to get a baseline. Talk to them in a normal tone of voice. That's what I would do. And then if they can't hear you, then elevate your voice as needed. Because a lot of geriatrics, they find it offensive for you to just automatically think they can't hear or understand just because they're older. So don't assume that they can't hear, and don't assume that they're mentally altered until you see otherwise, just to not offend the patient. Of course, vision impairment, that's a big one too, memory loss. And when talking about the intention, it's talking about teeth. So these patients that have dentures, for example, they lose teeth. So one thing, since I'm talking about dentures, is if you have a patient that has dentures and you have to ventilate them with the BVM, you do not have to take those dentures off. If anything, you want to leave those in place because they're going to help with the seal from the BVM mask. Now, the only time you take those dentures out of there is if they actually become dislodged and now they're obstructing the airway. But if they're staying intact, do not touch them. Just leave them in place. And then it says here, residual effects of stroke or dementia. So for those of you that don't remember, a stroke, I like to compare it to a heart attack. So because in a heart attack, what you have is you have a clot in one of the vessels that feeds the heart itself, right? So if you have a clot in one of those vessels, that means that a part of your heart is not getting oxygen and it's starting to die. Well, a stroke means that there's a clot in the brain, in one of the vessels that feed the brain. And there's a clot there, then a part of that brain is not going to get oxygen and is going to start to die. It's just how the tissue of the heart does not come back to life, whatever's dead stays there, stays dead, that's pretty much how the brain functions too. Now, the brain can make new pathways and rewire itself, but though the tissue that's dead is going to stay dead. And I actually found a pretty decent video on this as well, so I'm going to show it right now. Just let me read the last bullet and see what if I can say anything about that. First, assume altered mental status as a result of present injury illness. Yeah, so if your patient is mentally altered, and let's say you're coming up to a car accident or just any call in general, go ahead and assume that them, if they are mentally altered, so now you've identified that they are mentally altered, that it is as a result of the actual injury or illness, the chief complaint that you are there for. Okay. And then of course the way you know that is by either looking through their charts, a caregiver, family member, anybody that's there to take care of that person if there is somebody there. And let me find that video to share with you guys. Vascular dementia. Here we go.
Vascular dementia refers to a group of conditions in which impaired blood supply to the brain causes neuronal dysfunction, leading to loss of memory and other cognitive abilities. It is the second most common type of dementia after Alzheimer's, a neurodegenerative disease. Vascular dementia may develop following a stroke or a series of mini-strokes. A stroke can be ischemic or hemorrhagic. An ischemic stroke happens when a blood clot blocks an artery, interrupting blood flow. Blood clots may form locally on top of cholesterol plaques as these rupture, or travel to the brain from the heart in a condition known as atrial fibrillation, where the heart does not pump properly, blood stagnates and coagulates. Hemorrhagic stroke, on the other hand, occurs when an artery leaks or ruptures. This can result from high blood pressures, overuse of blood thinners, anticoagulant drugs, or abnormal formations of blood vessels such as aneurysms. As a hemorrhage takes place, brain tissues located beyond the site of bleeding are deprived of blood supply. Bleeding also induces contraction of blood vessels, narrowing them and thus further limiting blood flow. Dementia symptoms may appear suddenly following a single large stroke, or develop in a stepwise fashion as a result of multiple, sometimes unnoticeable small strokes. Symptoms vary from person to person depending on the part of the brain that is affected, and may include problems with memory or thinking skills, confusion, mood changes, speech disorders, impaired balance, and movement. The way the symptoms appear can be used to differentiate stroke-related dementia from Alzheimer's disease, which usually develops gradually, with specific symptoms appearing in a largely typical order. But vascular dementia may also progress silently in a continuous manner as a result of age-related vascular wear and tear, or any conditions that damage or narrow blood vessels over time, such as high blood pressure, high cholesterol, diabetes, and amyloid deposit. These factors often affect smaller blood vessels deep inside the white matter of the brain, causing small blockages and microbleeds that often go unnoticed to the patients. This is known as cerebral small vessel disease and is the most common cause of vascular dementia in older adults. Another cause of vascular dementia is hypoperfusion of the entire brain. This may result from heart failures, hypotension, or carotid artery occlusion. There is no cure for vascular dementia, but prevention by controlling vascular risk factors, such as high blood pressures, can be effective. Lifestyle changes such as healthy diets, quitting smoking, and physical exercise have been proven to be beneficial. Treatment is by managing the underlying conditions.
All right, so always try to communicate directly with an older patient rather than asking others about her. That again, that goes back to just being respectful. Don't assume that they can't speak for themselves, they can't think logically. Always just talk to them like anybody else, and then go from there. Depending on your response, that will kind of guide the rest of your call and how you're going to handle this patient. See, scene size up and safety. Look inside and outside residents for clues to physical and mental abilities. So yeah, as you're walking into the patient's residence, you kind of get a pretty good idea of how this patient is living just by walking into the residence. How's the yard? Is it made? Is it not made? Are there just piles and piles of dishes on the sink that haven't been washed for weeks? Things like that that kind of tell you a little bit about the patient. Are they able to take care of themselves? How's their mental status? Things like that. See, so condition of residents, half-eaten food, house dirty or clean, items left out that patient can trip on. So just to give you an idea of how the patient is doing. See, older people are twice as likely as younger people to use EMS. I would write this as a note only because I feel like I've seen this somewhere before, like on a test somewhere. So I'll give you guys 30 seconds or a minute. Just write that little note down right there. It'll help you out down the road, I'm pretty sure. Now, why they are twice as likely to call? Could be for one or two reasons. One is they're just really worried about if they feel any issues or they feel abnormal. The other one is sometimes older people sometimes don't have anybody to talk to, so they just become frequent callers just because they kind of need that attention. So they'll make up sometimes excuses, or maybe they'll even really feel like they are ill in one way or another. But those sometimes tend to be the patients that are alone and have nobody to come see them. But regardless of if that is the case or not, just remember to be respectful and kind, because they still are patients. So that's really important. See, finding a radial pulse in an older patient is usually no different from finding a pulse in other patients. True. The one thing that you have to look out for, though, in your geriatric patients is having those abnormal heartbeats. Sometimes you'll encounter thready beats that are just really rapid, really thready. You can barely feel them. Other times you'll have an abnormal heart rate, but that's their normal. It'll be like a beat, beat, pause, beat, 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 pause, beat. That's one example of an abnormal beat that's their normal for that person, for that patient. So things like that, you will encounter those, but like any other patient, you just take it in the radial pulse. But just and the reason I'm saying that is because I wasn't told that when I went to EMT school, or nobody told me that. So the first time I encountered that, I was just confused because I couldn't understand why their heartbeat was so different. And then the more patients I got, the more I started realizing, oh, the geriatric population, like they just have different heart rates. And it's because of illnesses or medication they're taking, things like that. All right, so secondary assessments. Take time needed to get full information. With geriatric patients, just understand that there's a good possibility that you're gonna take longer with this population than you would with any other population, okay? Because they are slower. They are reacting a little bit slower. Functions are starting to decline. So just give them time. Find out whether patient is compliant with medical advice. So meaning, is this patient taking the medication that's prescribed to them by their physician, or are they not? Ask family members, other familiar with patient's conditions. Physical exam and get your baseline vitals, obviously. See, anything here that stands out? So pelvis and extremities. Hip and proximal femur commonly fractured in falls. So yes, this is very common. This is a very common fracture. It's gonna be a hip fracture, or really it's a It's the femur fracture, but the very top part of the femur. Weakening of bone results in injuries to wrist and proximal humerus. This right here, I would write down the very last part where it says pelvis and extremities, specifically where it says hip and proximal femur commonly fractured in fall for your geriatric population, the elderly population. So go ahead and write that down real quick. It's gonna serve you well down the road. All right. A shingles rash often appears as a narrow. So shingles is chickenpox. So it's I guess the chickenpox doesn't really go away. It stays dormant in the body, and sometimes when you're in your older ages, it just comes back, but it comes back as shingles, and it looks like this, and it's usually it is on the torso, and it's explained as a belt-like band, just like it says here. Ages blistery, no, but also you have to understand that just because you're not in the elderly population does not mean that you cannot get this. If one of these blisters do burst and comes on you, and gets in contact with your skin, you can get this and have a reaction yourself. Now, usually it is found on the torso, but not always. This could appear on any part of the body, but usually it is found in this section. And remember, if you see this, be very cautious because you can get it if the fluid gets on you. See pelvis and extremities, check extremities for edema and swelling. Again, those that would be an indication of heart failure, special pedoedema. Remember, pedoedema means fluid in the ankles. See, when significant, these can be signs of underlying heart, vascular, or liver disease. It's like we talked about. See, spine, very commonly injured in motor vehicle collisions. So the one thing about the elderly population is you have some people with the curvature in their back. Some people call it a hunchback, and also on top of that, these patients have sometimes have fragile skin. That means or thin skin, and can be broken easy. So with that in mind, you really want to make sure that if you're gonna put a geriatric person on a spine board, make sure that you absolutely do need to put them on the spine board, because this patient is going to be very uncomfortable on that spine board. You're going to have to really apply a lot of cushion under the voids around the curvature to compensate for the curvature. On top of that, when the vertebrae are pressing down on the skin, there is a potential for that skin to break and cause more issues down the road. So that's why I'm saying be very cautious when thinking about putting a geriatric person on a spine board. Make sure you really have to do that if you're doing it. See, do best to keep vertebrae in line and reduce patient discomfort. See, reassessment, more common for older adults to show a slow, steady decline in condition. Again, that goes with compensation. They can't compensate as well, so you're not going to see that rise right before the decline. All right. You may be lulled into false sense of security, and that false sense of security again comes from that patient gradually declining and not compensating, not going all the way up before they come all the way down, because that's when we see that crash. See, reassess at regular intervals. So every 15 minutes, if there's nothing wrong with them, if you think that they may have an issue or may crash, no more than 5 minutes in between your checkups or your reassessments. Yeah, and mental status, maintain open airway. See, talking with a patient during transport can be therapeutic for the patient and enlightening for the EMT. That's actually very true. one, the patient, usually, not always, sometimes you have those patients that just don't want to talk to you, and that's okay. But usually patients are pretty eager to talk to you if you're in the back of the rig with them. At the same time, they can teach you a lot. They really can if you just listen. All right, we're taking a little 10-minute break, guys. So I'll see you guys in 10 minutes. All right. So medication side effects and interactions. So drug-patient interaction can occur because of inability to clear medications from body as quickly as before. Drug-drug interaction, when two drugs interact in the body. That doesn't really affect your NREMT. See, older patients often take multiple medications. That is true. So if you go to a geriatric patients, um, it wouldn't be uncommon to see it like this, or actually see it a lot worse. Sometimes you'll go into a patient's house and you'll see a whole bunch of different pills in just one container. So that's just something to know. Shortness of breath. So can result from diseases that cause this symptom in younger patients, like asthma as a good example, pulmonary embolism. So they're just like any other patient. Shortness of breath, they're gonna have the same medical issue as a adult patient, a pediatric patient. The only big difference is the reaction to that illness is slower. The sensation is slower, and it's because of that decline in function. Elderly patients are more likely to have emphysema. Of course, that's because emphysema is one of those illnesses that occur over time, and usually it's because of exposure to environment or smoking, or a combination of these diseases. See, chief complaint of patient experiencing a cardiac problem. So yes, a lot of your patients that are have angina, so chest pain because of a cardiac issue, they will also present with shortness of breath. That is true. So chest pain. So complaint of chest pain can indicate many conditions. Angina in itself, angina is just, that means pain from a cardiac. So the origin is cardiac. That's where the pain is coming from, okay? Myocardial infarction is a heart attack. And so myocardial infarction, which is the exact same thing as a heart attack, means that you have a clot in one of the arteries, one of the vessels that feed the heart itself with blood. So if you have a clot there, you're gonna have a piece of a heart that's not getting oxygen. So pain will come from that. That pain is called angina, okay? Pneumonia, if they have infection in the lungs, that does cause pain. Any infected part usually is painful. And aortic aneurysm. So an aneurysm, remember, an aneurysm means that there's a bulge coming out of one of the vessels in the body, and that's because a section of that vessel, the layers of that section have become so thin that they're bulging out from the pressure. Just like when a water hose, when you lose that top layer of water hose skin, or whatever you want to call it, the interior part will bulge out when the water is rushing through it. It's the exact same concept. See, altered mental status. So these are all the reasons why your patient may be mentally altered. Adverse effects from medications, we kind of talked about that. Hypoglycemia means that they have low blood sugar. And again, you need oxygen and glucose to make ATP, right? To keep your body going. Your brain also needs this. So if there's low sugar in the system, your brain is not being fed good enough. A stroke, which means that there's a clot in the brain, so a section of the brain isn't gonna get blood. That's gonna cause your patient to be mentally altered. Sepsis means it's a system-wide infection. The infection spread and got throughout the entire vessels of the body, which falls under the same lines as generalized infection in bloodstream. Sepsis could be put right underneath that. Hypothermia, everything is slowing down because of cold temperature, which could also lead to a patient being mentally altered. and then pneumonia by itself. And the pneumonia, I would contribute pneumonia to your patient being mentally altered because of the fact that it's interfering with that gas exchange from the alveoli to the capillaries, the alveoli to the capillaries, that gas exchange. And it's because of the infection itself, but also from the fluid that's going to that area, which occurs with almost any infection. Fluid is attracted to that area. You have white blood cells that are going to rush to that area, and plasma. Abdominal pain and gastrointestinal bleeding, often a sign of serious conditions such as, and here's the list of them. So again, that aneurysm, abdominal aortic aneurysm against a bulge. That means that the biggest artery in your body has a bulge in it from that pressure. Bowel obstruction or blockage, of course, that would cause pain and could do other issues in there. And I think it's pronounced diverticulosis. That means that little sacs are forming in your large intestines. And I actually found a video on that, so I'm going to show it to you guys right now. That explains it a little better than I can.
Diverticular disease, also known as diverticulosis, is the presence of small sac-like outpouchings of the lining of the colon that balloon through the outer wall. These pockets are called diverticuli. Diverticulosis can be present without noticeable symptoms, but might be associated with constipation or diarrhea. This condition is very common as we age, but still affects young people. More than 65% of those 85 years of age and older have diverticular disease. A person might have one diverticulum or hundreds of diverticuli, which are typically less than 1 centimeter in diameter, but tend to increase in number and size over time. In about 10 to 25% of people, the diverticuli can become inflamed or infected, known as diverticulitis. This leads to distinct symptoms, including diarrhea, cramping, bowel irritability, intense pain, bleeding, bloating, and fever. The pain and tenderness is often felt in the left lower portion of the abdomen. Rarely, serious complications can occur, sometimes requiring urgent surgery. Researchers aren't sure what causes diverticular disease, but it does seem to be more common in those who don't consume enough fiber. One theory is that pressure, such as straining during constipation, builds up inside the colon, causing the intestinal wall to balloon out between muscle bundles, which run both lengthwise and circularly through the colon. To diagnose diverticular disease, a physician will likely consider your symptoms and might use a colonoscopy to observe the shape and function of the colon. During periods of flare-up, the bowel might be too tender to perform these investigations, and the risk of bowel perforation might be too high, so a physician might choose a CT scan or a procedure known as virtual colonoscopy. Blood tests can also help to analyze for levels of inflammation in the body. The best way to avoid diverticular disease and to manage it is to consume a well-balanced diet, ensuring high fiber content and adequate fluid intake. Fiber and fluid help soften stool, allowing it to move more quickly and easily, thereby avoiding excessive pressure against the colon wall. However, treatment is quite different if you are experiencing diverticulitis. A physician will likely recommend an immediate transition to a restricted fiber or liquid-only diet and physical rest, pain medications, and possibly antispasmodics. Although often used, there is growing evidence that antibiotics might not be needed in uncomplicated diverticulitis. In severe cases, you might need to be hospitalized for intravenous feeding so that the bowel may rest for a few days. If episodes become frequent, then surgical removal of the affected area might be necessary. Once a diverticulum forms, it does not go away on its own. Therefore, it is best to try to prevent the disease from developing or progressing further by following a well-balanced, high-fiber diet, drinking adequate fluids, and staying physically active. Many people are able to live symptom-free with diverticular disease by making these lifestyle changes. Medical and surgical treatments are available for those whose disease is persistent. Go to www.badgut.org for more information.
Sorry, I was muted. I thought you guys were hearing me. All right, so that's what diverticulosis is. So another thing that could be causing the bleeding could be ulcers. So that would be down here, and ulcers is just an opening in the tissue that could occur inside the GI tract, and that would of course cause bleeding inside of your patient's GI tract. Adverse effects to medications always are going to be on there for geriatrics. See, do not take complaints lightly. So yeah, so if a patient is complaining of pain, usually, I mean, not usually, but it can be a big deal. Again, it's because they don't feel pain like we feel pain usually. They're slower to react, and the feeling is less sensitive. So if you have a geriatric patient that is complaining of pain, you want to actually pay attention and take it seriously, just to be safe. Can be associated with a number of serious conditions, obviously, can be threatening, life-threatening, and again, it just is situational. Depression and suicide in older adults can be caused by, so these are all the reasons why your patient could be depressed or suicidal. And again, we're talking about the geriatric population. So this does not apply to it doesn't apply to all adults and pediatrics, it's geriatrics. Conditions that limit activity. So again, as the body declines, these patients are not able to do as much as they used to. So that's going to affect them mentally and psychologically as well. Medications that sap energy, of course, loss of friends and spouse, whether it's from just arguing or them passing away, biochemical imbalance. Shingles or herpes zoster. So we talked about shingles already. You guys saw that patient with the belt, the blisters on their torso, a belt-like band around the torso, scabs up. Don't let it get on you. So this is big right here. So geriatrics do tend to get fractures from falls pretty frequently. So that is a common cause for a fracture in a geriatric, and that may very well be a question on the NREMT. So death may result from complications of falls, bruised ribs, cannot cough because of pain. So if your patient can't cough, they can't expel the bacteria inside the lungs. So then pneumonia builds up, okay? So that's why that can become an issue. May indicate more serious problem. Abnormal heart rhythm. So sometimes it is normal for your patient to have an abnormal heart rhythm. That is their normal baseline. Stroke, internal bleeding. See, assess for cause of fall as well as injuries from fall. So what this is saying is that maybe the patient fell down because of a stroke. Maybe they had a heart attack and they fell down. So don't just worry about the physical that occurred, the trauma that you're there for. What if it was a medical that led into a trauma? So that could also be a situation. So look out for that. See, elder abuse and neglect. Ways in which older adults can be abused or neglected physically. So they can be hit psychologically and financially. Can be difficult to detect. Yeah, sometimes. So usually an abuser will usually always be someone you love. It's always a family or friend, regardless of what the abuser is or the demographic of the abuser. So because of that, if a geriatric is being, let's say, financially abused by their daughter, then there's a very high possibility that they're not going to want to report them because they don't want to see their daughter go to jail. So that's why it makes it difficult to detect that. Many states have laws that require reporting of suspicions. See, effects on relationships. So over time, one member of a couple often becomes a caregiver for a sick partner. That is true. See, if caregiver becomes sick or injured, their situation may become difficult or impossible. Caregiver guilt or burnout. Okay. So this is just something to look out for. You may need to make short-term arrangements for the partner. So this is shingles on the face. So like I said, it doesn't always have to be on the torso, and this looks like it's extremely painful for this guy. And here's a video that I'm gonna share with you guys as well right now. So share you.
Alzheimer's disease is a progressive, degenerative disease of the brain, characterized by loss of memory and other cognitive functions. It is the most common cause of dementia among people aged 65 or older. The neurophysiology of this disorder consists of alterations in the cerebral cortex, senile plaques, neurofibrillary tangles, and atrophy of the cerebral cortex.
Yes, he has. I saw him last night.
Alzheimer's usually begins after age 60, and risk increases with age. At first, the only symptom may be mild forgetfulness. People may have trouble remembering recent events, activities, or the names of familiar people or things. People in the middle stages of Alzheimer's may forget how to do simple tasks, like brushing their teeth or combing their hair. They begin to have problems speaking, understanding, reading, or writing. Later on, people with this disease may become anxious or aggressive, incontinent, or wander away from home. Eventually, patients need total care. The cause of AD is not known, and there is no cure. Suspected risk factors include age, family history, diet, and environment. Viruses are being studied to learn what role they might play in the development of this disease. No treatment can stop Alzheimer's disease, but for some people in the early and middle stages of the disease, some drugs may help prevent some symptoms from becoming worse for a limited time. Developing new treatments for Alzheimer's is an active area of research. Scientists are testing a number of drugs to see if they can prevent, slow the disease, or help reduce symptoms.
All right, here's another one, I guess. Let me show that one.
Elder mistreatment is the outcome of abuse, neglect, exploitation, or abandonment of older adults, and represents some of the most tragic behavior in the area of family violence. Any action or inaction that caused harm or endangers the welfare of an older adult may be considered elder mistreatment. Types of elder abuse include physical abuse, psychological or emotional abuse, sexual abuse, financial exploitation. Self-neglect, when the older individual exhibits personal disregard or inability to perform self-care. Institutional mistreatment and abandonment. There are approximately 1.2 million cases of elder mistreatment in the United States each year. Healthcare staff working with older adults must be aware of local elder mistreatment reporting laws. Many states have mandatory reporting laws, and healthcare professionals must, by law, report suspected cases. There are three basic categories of elder mistreatment. Domestic mistreatment generally occurs within the older adult's home dwelling at the hand of significant others such as their child, spouse, or in-law. Institutional mistreatment occurs when a senior has a contractual arrangement and suffers abuse at places like long-term care facilities, assisted living, or hospitals. Self-neglect occurs when elders who are mentally competent enough to understand the consequences of their own decisions engage in behaviors that threaten their own safety. Older adults who are victimized are more likely to be 80 and above, female, and be living with their abusers. Elders who suffer from chronic, disabling illnesses that impair function and create care needs that exceed their caregiver's capacity to meet these needs are at higher risk of being mistreated.
All right, guys. So that's all for me today. Tomorrow we are gonna be covering special considerations. Okay. And if you guys don't have anything for me, I am gonna close out.
I just have
Yeah.
I have a question about the ride-alongs. Like, I went Saturday, and I just have all the, like, every patient, their, like, couple sentences. And so
Okay.
just gonna email those to you, and that's it?
Yeah, you just take a picture of it and send it to me, and that's it. Just email.
That's just the patient contacts, right?
Yeah, just make sure that on the topic you put patient contact forms. That way I can find it easier.
Thank you.
All right, and Desiree, I got yours, so thank you.
Okay, good. Thank you.
All right, well, you guys have a good night.
Good night.